Hi class, it's Jamie Batts, your instructor for A&P2. We are finishing up our last lecture, which is on the reproductive system. This lecture we're going to talk about some of the kind of clinical applications of the reproductive system, and I'm going to switch to screen share. There we go. And that's where we left off. Here we are. We're going to talk about birth control strategies. This is kind of like a review of high school health class, if you will. Obviously, we have male condoms being one of the primary choices for birth control uses. It covers the shaft of the penis and the glands of the penis, so sperm are unable to reach the female reproductive tract, and this is the only strategy that protects against STDs like syphilis, gonorrhea, HPV, HIV. There's also a diaphragm with spermicide. This is a dome-shaped silicone cap. Has a flexible rim and it kind of squeezes into the vagina, and it has to be fitted individually, so it's not something you can just go to the drugstore and purchase. It's inserted prior to intercourse and covers the external os of the cervix, serving as kind of a reverse condom, right? This is on the female instead of on the male. It has to be coated with the spermicidal jelly in order to be effective. Failure rate is 5 to 6% even with proper fit. There are also oral contraceptives, which are typically combined estrogen and progesterone hormones. They are the most effective form of birth control when they're used as prescribed, which is often tricky because you have to remember to take the pill every single day at the same exact time every day, and any variation of that could result in failure of contraception to occur. So there are health risks, though, because you are putting hormones into your body, so it can worsen hypertension, diabetes, or epilepsy, even gallbladder disease or heart trouble, as well as bring on acne. It can also lead to an increased risk of certain disorders, usually dealing with the cardiovascular system, such as DVTs and strokes, pulmonary embolism, and for women over 35, it can increase your risk for heart disease. So, again, the condom is usually the preferred, safest, and easiest method when it comes to side effects and things like that. There is also a progesterone-only version of the pill, which can be taken daily, as well as the estrogen and progesterone combined pill. But there's also a progesterone injection in the form of Depo-Provera, which is an injection every 3 months. And basically, this is helping to bring about control the uterine cycle from a progesterone input standpoint instead of the balance of estrogen and progesterone. Sorry, I lost my train of thought there for a second. There are also IUDs, or intrauterine devices. I'm trying to think of the ones that are on the market. Mirena, I think. Mirena and Paragard, I think, are the two that are IUDs. There may be others. I'm just not familiar with them. It's basically a little T-shaped or loop-shaped device that goes into the uterine cavity, and it's going to stimulate the prostaglandin production, and the prostaglandins will help control the sperm from entering the uterus and therefore the fallopian tubes or uterine tubes. So this can be left in for years and years and years and maintain its efficacy. There's also the natural family planning method, or rhythm method. Rhythm isn't referring to the intercourse itself. It's referring to when you have intercourse or when you abstain from intercourse. So abstaining from sexual activity during the days of ovulation is referred to as the rhythm method. I remember learning about that in high school and thinking that was not, I thought that it was referring to the actual pace of intercourse, if you know what I mean. And that just sounded really strange to me. So that's why I wanted to address that. You're probably laughing at me right now. So this is basically just using timing based on patterns and physical changes like your cervical mucus texture, basal body temperature, and you can do urine test for luteinizing hormone as well, which is probably a little bit more accurate than just saying, I think my cervical mucus is on point. Maybe I should, not have intercourse today, whatever. It has a very high failure rate because it is very subjective, and every woman's cycle is a little bit different, and there's so many variables. that can contribute to irregularity in a woman's cycle. So there's also a postcoital contraceptive, Plan B. It's also called the morning after pill. This is taking a contraceptive pill up to 5 days after having unprotected sex. And this is basically going to prevent the ovary from releasing an oocyte for longer than usual. So it's going to prolong ovulation, set it back. It can also prevent the oocyte from joining with sperm. So it's not, if fertilization has already occurred, it's not going to work. It's only going to work if sperm and egg have not met up yet. It does reduce expectant pregnancy rates, and the efficacy is going to decrease with time, so you have to take it as soon as you know. Otherwise, fertilization may have occurred. It's not going to induce a miscarriage. This can be purchased over the counter. There's also surgical sterilization. In males, it's called a mastectomy. The ductus deferens is cut and blocked. Usually it's a segment that is removed. I think I discussed that earlier when talking about male anatomy. They typically will tie or cauterize the ends of the ductus deferens. It can be reversed, but if they remove a very large segment, reversal is almost impossible, depending on the size of the segment that they remove. So it can be performed very, very quickly. It's an outpatient procedure. Failure rate is very low. There's no disruption to sexual function, erection, ejaculation, that all occurs. There's just no sperm, obviously. The sperm are produced, but they just disintegrate and degenerate within the male reproductive tract itself. In females, it's called a tubal ligation. This is when the uterine tubes are cut and tied. This can be done laparoscopically. It's a much more involved procedure. It requires general anesthesia. Complications are much more likely to result from tubal ligation. The failure rate is extremely low, however, so if for some reason the man does not want to undergo a vasectomy, the female can have a tubal ligation, but it is a much more involved, much more expensive and risky procedure. So these are just pictures of all of the things I just mentioned, looking at how that cord is cut, both male and female versions, and you can see the IUD, nice and T-shaped. You can imagine it sitting inside of the uterus and kind of holding itself there. I just looked at myself. I am wearing a shirt. Doesn't look like I'm wearing a shirt. Promise, I have clothes on. You can pause the video here and go back and review this section. We are going to finish this lecture by talking about disorders of the reproductive system, beginning with prostate disorders. There is BHP, or benign prostatic hypertrophy. This is fairly common over the age of 40. Declining testosterone production, presence of estrogen can stimulate this growth. This is when the prostate becomes enlarged. It can actually constrict the prostatic urethra and affect urination. If you ever known any old men that are having trouble urinating, this could be why. I say old loosely. 50 is not old. So I did not mean to offend anybody. Prostate cancer is another one. This is the second most common form of cancer deaths in males. It can be screened by simple blood tests looking for PSA, prostate-specific antigen, and treatment is radiation or cervical removal of the prostate itself. And there you see that enlarged prostate in BPH, benign prostatic hypertrophy. Obviously, it's blocking urine flow and could cause painful bladder, kidney infections, difficulty urinating. There's also testicular cancer. This is the most common cancer in males ages 15 to 35. It has a very low rate, but in terms of this age group, this is the #1 cancer. 95% are resulting from abnormal spermatocytes or spermatogonia. And the treatment is a combination of testis removal and chemotherapy. Survival rate is 95% with early diagnosis and improved treatment. So if you notice something down there, you got to do the old turn and cough method to check those testicles, make sure that there's no growths on them. And maybe that's what you look like when you're, never mind. I should not be recording some of the things I say. I'm sorry. There are breast disorders, like changing hormone levels can cause inflammation of the mammary glands. And this could be a result of cysts, which are basically inflamed lobules. Like fibrocystic disease is the condition when clusters of cysts can be felt, and it's a very benign condition, and biopsies will distinguish that from breast cancer. So if you do find a lump in your breast tissue, it's not always breast cancer. It could just be fibrocystic disease. Then there's breast cancer is the other option. This is typically it is malignant and metastasizing, and it's the leading cause of death in women ages 35 to 45, but it's very common in women over 50. The notable risk factors are family history of breast cancer. There are genes that are related to breast cancer. I should say there are genes that when mutated, they are related to breast cancer occurring. If you have your first pregnancy after the age of 30, that increases your risk for breast cancer. And if you have a very early menarche or very late menopause. In other words, the more you ovulate, the higher your chances of breast cancer. So stopping ovulation by being pregnant a lot, or by having early onset menopause or very late first period, you will have a lowered risk of breast cancer. Treatment includes surgeries, radiation, hormones, chemotherapy, surgical removal of the mammary glands, as well as the axillary lymph nodes, which is why breast cancer is so dangerous, because it is right next to those axillary lymph nodes. It's very quick and easy to metastasize, and since our lymphatics are very slow moving and infiltrate the entire body, once some cancer cells get into the lymphatics, it's very easily spread to other organs. There is a breast cancer with calcifications around it. Typically, the body will calcify anything that is not normal or does not belong. There's also ovarian cancer in females. It's the third most common reproductive cancer and is the most dangerous because it is seldom diagnosed. 1 in 70 chance of developing during a lifetime, and is very aggressive chemo, radiation, and surgery to treat it. The prognosis for cancers originating in the ovarian tissues is relatively good if it's detected. That's the problem. It's very hard to detect. 85% of ovarian cancers are epithelial cancers, and they have a sustained remission of only 1/3 of cases. So it is hard to control because it's very hard to detect. Because your ovary is on the inside. It's not like you can just turn your head and cough like guys can to test it and to feel them out. So this is why you need to be going very frequently to the GYN. I think it's once every year. They always change those quantifications, but go regularly so that you can get checked for that. Cervical cancer is another one. This is the most common cancer of the reproductive system in the younger age group, 15 to 34. And another 35,000 cases per year are diagnosed as a less aggressive form. Human papillomavirus, HPV, is responsible for a large majority, 75% of cervical cancers. There is a vaccine, a highly debatable vaccine, I should say. I'm not anti-vaccinating. Obviously, I'm a science person, but there has been some shady science around Gardasil in several different studies and research articles. So just be informed. I'm not saying it's bad for you, but I'm not saying it's good for you either. I'm just saying do your research. It has been known to protect against 4 types of HPV. There is cervical cancer. And finally, we get to STDs, are sexually transmitted diseases, and sexually transmitted infections. These are transferred from person to person, mostly through sexual intercourse. Consequences can just be like a small inconvenience to being deadly. They include at least 24 bacterial, viral, and fungal infections, like chlamydia or HIV/AIDS. So the incidence is actually increasing in the United States since 1984. There are 20 million new cases a year, and 50% of them are in that low age bracket of 15 to 24. So that's like high school and college aged kids, people. Because when you're 24, you're not a kid. The contributors include poverty. When you're poor, you don't have access to, if condoms cost $10, you're not going to go and buy condoms. You're probably going to go buy food, right? Intravenous drug use, because then you're inhibited and you are uninhibited and you don't care about using protection. Prostitution and drug-resistant pathogens can also lead to STDs. So that concludes the last lecture of your A&P life. Are you doing happy dance now? I don't know. Maybe you're not, because we just got done talking about STDs and maybe you're paranoid. So again, I look naked. I'm not. All right, guys, have a super awesome day. And let me know what questions you have about this section. It's very straightforward. Again, most of this was like high school health class level. We didn't really get into all of the ins and outs of, no pun intended, of the reproductive system in terms of diseases and disorders. So yeah, have an awesome day, and I'll see you guys in class. Bye.